service. Our transition clinic started in its current form back in 2011, so it is approaching sort of 10 years old, and we've kind of felt for a while that it doesn't quite work as well as it has the potential to. We've got a dedicated adult and paediatric team who work very well together, but we just didn't feel that we were quite meeting our true potential. I'm sure, like many people, one of the dominant themes of our presentation and our work so far is the fact that it's been QI in a time of COVID. This picture of a woman lying on a bed in despair is how I felt about the QI project at times. And I think it really has dominated both what we have and haven't done so far. So this is our team. I didn't have a picture of us all. So we're quite a big team working on this project. It's our adult diabetes team who work with the young people in the transition service, and our full paediatric team who are all working together on this. We've known for quite a while that we look after more 16 to 19-year-olds than other comparable units. This is probably a measure of the success of our transition clinic, that we've been keeping these patients up to the age of 19 for a long time, and they form about 40% of our overall paediatric service. We've known from the national audit data for a while that although we've got a good median HbA1c as a whole, we have more patients than comparable units who have a high HbA1c. And we've always had a bit of a sneaking suspicion that was this the teenagers who were affecting our numbers. And this was confirmed a couple of years ago by some network benchmarking data, which is shown here, where the red blob and the blue blob is the rest of our network. The size of the blob tells you how many patients you have at a particular age group. 1 is 0 to 5, 2 is 5 to 10, but the 4 group is 15 to 19. So we can see that we've got far more of these patients and they have a higher HbA1c than the network average, where at every other level our unit HbA1c is slightly lower than the network average. We did wonder a little about the data quality. Were we comparing our 17 and 18-year-olds with other units, 15-year-olds? But regardless of that, we've got a definite big jump in HbA1c in this age group, and we wanted to try and bring that down. So we've looked at how our transition service works. We've mapped the processes, we've done the driver diagrams. One of the big problems we identified was before we even got people into clinic, the clinic was very underutilised. We'd often have slots that weren't booked. There's a high cancellation rate. Often this is very late. The nurses will get texts from patients half an hour before the clinic starts saying we can't come. Our DNA rate, although this is a group known for sort of DNAs, isn't that high, but we do have a very high late cancellation rate. So these are probably just politer DNAs where they let you know that they're not coming, but they do it so late that we can't really utilise the appointment for someone else. We also haven't had dedicated reception staff because our clinic takes place in the late afternoon, early evening, which means we've had problems getting patients booked in for their next appointment. And there was no real sense of ownership from an admin point of view about who runs this clinic and who ensures patients have an appointment. And often if patients cancel, they're just booked in again for 3 months' time, which means it can be a very long time before we get to meet the patients. So we felt that there's no point improving the clinic if we didn't have the people there to make use of it. So this is one area we're concentrating on. We also felt that the patients didn't get a great introduction to the clinic. They didn't necessarily understand what was different about transition compared to their normal paediatric clinic. And also we didn't introduce the patients very well to the new members of the team. The paediatricians and the paediatric team understood these patients and their families very well, but we weren't very good at sharing that knowledge with the adult team in a formal way. So we've looked at ways at which we could do a sort of page profile of patients so that everyone in the team knew about them, the salient features of their family history, their clinical history, what works with them, what doesn't. And we've also looked at some of the other work that other people have done on transition about what we need to prepare our patients for to be young adults operating in the health system. We do use the Goals of Diabetes curriculum, but we haven't done this in a very formal way, and we haven't been using other pathways such as Ready, Set, Go, which we could look at utilising with these patients. And we've also got lots of ideas, but we've got absolutely no idea what our young people in transition think about our service and what they would like. So we need to ask them. What we've found so far is that we don't like homeschool. We don't like it for our own children, and we found it frustrating at times. Trying to do the QI learning from a distance. We know it's very much a necessity and a necessary evil, and it's not a criticism, but at times we felt a bit lost with some of the tasks where we felt if we were doing it in a classroom, we could just ask a couple of questions, clear it up, and move on. We've also found finding the time to do some of this work quite challenging. If we'd all gone to Leicester on an away day, would have used study leave, would have blocked that time out, would have cancelled clinics or rescheduled them, whereas finding time for us to work together for an hour or 2 hours here and there has really been very challenging. We've also felt that virtual meetings have been quite limiting, where we just sort of wanted to be face to face with a big pad of paper and some post-it notes, and trying to do it on screens with a whiteboard hasn't been quite the same. We've also found working across departments quite challenging. I've been trying to sort out the practicalities about our clinic booking, and the responsibility lies with the adult managers who view that this is a paediatric clinic and not their problem. We work across departments very well clinically, but we haven't got the same sort of managerial and admin support across departments. Unsurprisingly, the adult managers have got a lot else going on in their lives with COVID, and this really hasn't been a priority for them. All elective outpatient work has been cancelled in the adult world at the moment, so trying to sort out a paediatric clinic doesn't seem like a priority for them at the moment, and understandably so. And we've also had a lot of staff redeployed for the COVID response across the trust, so we haven't had people available to do some of the work on the patient pen profiles that we've started. That's kind of taken a bit of a backseat recently when a lot of the team has been redeployed to other areas. Our most important piece of learning so far is that we've got absolutely no problem in generating ideas and enthusiasm. We quite often leave every meeting saying, well, we could do this, and then we could do this, and after that we'll do that. But we actually need to work on making our ideas translate into change in practice. Laura, our psychologist, is very good at keeping us on track and making us make smart goals rather than leaving with big ambitions and nothing tangible put down. And we need to start small, but we do need to actually start. Sometimes we get overwhelmed by how much we want to change and we end up not doing anything.